So my grandma.
Oh, I'm sorry to hear that.
Yeah, she passed away exactly a year ago.
Yeah.
Wow, okay.
Yeah, she had breast cancer for like 6 to 7 years.
It's a long.
Yeah.
So my grandma.
Oh, I'm sorry to hear
Okay,
that.
hold on.
Yeah.
Okay, there. All right, we can wait for a couple people to join. Yeah, we can start in like a couple minutes. People are slowly starting to come in.
Good. I might just step away for 1 second. Do you want to start with breast cancer or do you want to start with EM?
Either one. It's your choice.
Yeah, okay. All right, and how long do we have? Just so I keep an eye on the time.
Just so we have an hour, so it's okay if you go like over a little bit, that's fine.
Okay.
But
All right,
we'll start in a couple minutes.
Okay.
Okay, I think we can go ahead and get started. So I'm just gonna give you a quick introduction. Hi everyone that's watching. This is Dr. Kavita Jackson, and she's an MD emergency medicine doctor. And she's also a breast cancer survivor. So we just wanted to have someone speak about both emergency medicine and breast cancer for the month of October, Breast Cancer Awareness Month. And she's prepared a couple presentations for us. I've also asked you guys to do your research and prepare some questions for her. So make sure you put that in the YouTube live chat, and we'll make sure she's answering, or she gets those questions to answer. And then at the end of the meeting, I'll send out a Google form for you to answer some questions, put in your research and your questions in order to get your shadowing hours. So without further ado, Dr. Jackson. We can't hear you. I think you're muted.
Sorry, I just, I have to start with, can you hear me now? Because that's like the Zoom thing that we all have to check. Thank you guys so much for having me. I'm really excited to talk to you guys and share my experience in EM and what it was like to have breast cancer this year. So give me 1 second. I'm going to actually just share my screen so you can see my PowerPoint. So go ahead and drop your questions. Oh, whoops. In the chat, although I may not see them. So I know they will be read out to me.
Yeah.
Okay, so this is me. I live in DC and I practice at a community hospital in Silver Spring, Maryland. So a day or night in the life of my life. So, you know, we work 24/7. That's days, nights, weekends, holidays, you name it, we work it. No two shifts are the same. Usually when I show up to work, I show up, I sign out, start seeing patients right away. There's no moseying. I don't get my 30 minutes of coffee and check emails. It's show up and get started. As you may know, we do see the sickest people first. So everyone that comes to the ER goes through a triage level, 5 being the lowest acuity, 1 being the highest acuity, like an active, you know, either a code or a stroke or somebody that needs immediate attention. I will try to front load on my shift, meaning pick up more patients towards the beginning of my shift so I can see them all and get them dispositioned by the end of my shift. I see about 10, you know, patients at a time and up to about 30 or more patients per shift. It all just kind of depends on the flow and, you know, the acuity and the complaints that are coming in. When you're seeing multiple people, they're all different ages, complaints, acuities, workups, dispositions, they need different consultations and things like that. I put phone calls here because I do spend a good amount of time on the phone, as many physicians do, especially those that practice in hospitals, whether it's consultants or primary care physicians, admitting doctors, family members, all sorts of people. Patient advocacy is something I think we don't realize how much we're doing, but we do it, especially in the emergency department, a lot. A lot of the phone calls I'm making, especially to consultants or to other physicians, is to advocate on the behalf of my patient. One thing, you know, you see an ER doctor calling and no one wants to answer because I'm going to ask you something. I'm asking you to do something. I'm giving you work because that's what I think my patient needs. So we are big advocates for our patients through multiple phone calls. I chart the best I can throughout my shift, and we have scribes, which is awesome. It helps me a lot. And then I dispo. That is the name of the game. You meet them, treat them, street them. Wherever they're going, get the patient moving, get them flowing. And then when it's time to be done, I sign out and I peace out. This is a really long list, but it's actually a short list of the type of pathology that I see in the emergency department. And I put this here just to give you an idea of everything that we see. These are things that I see on a daily basis. You could have one or multiple from each category throughout a shift. So really any life or limb-threatening emergency, that's what we're here for, but we see everything else. Anything that comes in, you're responsible for. This is a sample of my schedule. Actually, I think this was January of this year. This schedule depends on the group that you are working with, but I work an average of 120 hours a month. I need to work a minimum of 108 hours a month to meet for my benefits. And I usually work 2 to 4 nights a month. But there are months that I've worked 108 hours. There's months that I've worked 150 plus hours. I know some colleagues that are working 200 hours. It's pretty flexible and, like I said, group dependent. My shifts range from 8 to 10 hours. There are places where they'll take 12-hour or 24-hour shifts as well. And I work about 12 to 15 shifts a month. And one thing that's awesome is that we do not take call as emergency physicians. at least not in the classic sense. We do something that's called backup or jeopardy, depending on what institution you're working at. It's called different things. But basically, there'll be like a 24-hour period. I do it twice a month or so, where I'm the backup person. So if somebody calls out or they need help, or they just need extra hands, I'll get a call to come into work. That's the only call that I'm getting. So it's not like a usual call, because you're not getting called for patient questions, patient care, or anybody that actually needs you to do anything. If you get a call, it's going to be one call, and that is to come in. And people, I have not ever been called in actually in the last year, but I know people get called in time to time, maybe once or twice a month will activate Jeopardy. So within EM, there's a huge variety of things that you can do that's not just practicing in the emergency department. On the left-hand side, you'll see some of the more common fellowships that you can go for. And I'm actually realizing I forgot toxicology on here. That's a big one. And this is not a complete list. So there's so many different ways that you can advance through emergency medicine, through a fellowship. And it's about 50-50. So about half the people just go straight to work as attendings, like I did after residency, and the other half will go on to do fellowships. And that's, it doesn't have to be, but that puts you kind of more in an academic route. In your practice settings, you also have a lot of variability. You can be in academic or community settings. There's hospital-based ERs. There's freestanding emergency departments that are just an emergency department. And if anybody needs anything else, like a consultant or an imaging test that they don't have, or admission or further treatment, they need to be transferred to a hospital. And there's also urgent care. You can work at a center that sees trauma. You can work at a center at a non-trauma center. You can work at somewhere that sees adults and pediatrics. I was trained in both and I see both. Or you can be at an adult-only hospital, knowing that a peds case could still come in, right? An emergent case could still come in that you have to handle. Or like one of the hospitals I work at, we have in-house, PEM is Peds EM. I'm gonna try to say all my acronyms, so they're obvious what they stand for. So you can be working side by side with pediatric EM doctors as well that'll see peds and you'll see the adults. Available support specialties is really important, especially as you're graduating residency looking for a job. Who are the other people that you want in your hospital, right? So for me, I would need a surgeon. I want a surgeon, I want an OBGYN, and a neurologist, right? For my stroke cases, for any emergent surgical cases, and for deliveries. I don't want to deliver babies. I can, my preference is not to. So if I can call OBGYN for my pregnant patients, that's awesome. There's people that work in academic institutions that have a ton of specialties and subspecialties and special neurosurgeons and all of that. And then there's also people that work with just them and no other specialties. You can work urban, you can work rural. The landscape and the work you do is going to be different. You can work on RVUs, which is, now of course I'm forgetting what RVU stands for because I've never actually said it, but it's basically you're getting like a fee for service, right? Based on what you did for the patient, you get paid based on that. Or you can be salaried. You can be physician only, or you can have advanced practice providers working with you. That's like NPs, MAs, and PAs. Locums tenens is something I wanted to mention. That's where you are an independent contractor and you travel to wherever they need you, and they pay big money for you to come work a shift or two out where they are. And then I wrote airplanes, because the best doctor to have on an airplane when you need somebody is one of us. And really anywhere. You're anywhere, you see somebody collapse, you're gonna go run to them and try to help out. You can see our salary is right in the middle of the road. It's about, the average is $357K across the country, but there is significant variability regionally. So the more south you go, the more money you will make. If I was living in Texas, I would actually make double the amount of money that I'm making here in DC. So there's a big variability, but the average comes out about to $357. So some pros, I like the flexibility. I like that we get to do some really cool aggressive interventions and see immediate results. So you get immediate feedback on the interventions that you're implementing. We have a wide range of pathology, as you can remember from that list a couple slides ago, and I don't take call, which is really nice. I show up to my shift, I do my job, and when I leave, my time is my time. The cons and things that we have to deal with are the unpredictable nature of what happens on shifts. This is not a 9 to 5. This is the opposite of a 9 to 5. We have a lot of sleep issues because our sleep is disruptive from working varying shifts. As we mentioned, the nights, weekends, and holidays, EM does have a decent, if not the highest amount of burnout. And I think a lot of that is with the schedule and the intensity of the things that we're doing day to day. And there's no long-term patient relationships or follow-ups. Which for me, this is my personal preference, that was a con. The less people I'm tracking over a long period of time and following up sounded like less work for me. But that, you know, where that falls on your pro-con list, I think is individual. So these are some things that, you know, emergency medicine is right for you if you have a lot of interest and you want to know a little bit about a lot of things versus being super specialized in one subject. You like to multitask. And the first 2 points together, you know, there's this, I can't think of what it's called, but there's this idea that most of us have at least some sort of undiagnosed ADHD because we are jumping from one thing to the other. And we like to do that, and we seem to function better that way versus focusing on one task for, you know, hours and hours and hours like you might do in the OR. If you're calm under pressure and chaos and you thrive in those situations, EM is good for you. You can handle or enjoy intense experiences. That's both really good and also some really bad experiences. EM might be for you. You can get down and dirty and do what you need to do to get the job done. And I mean like physically dirty, you don't mind. This is a good place for you. Procedures, you may want to do some procedures, but you don't want to be committed to the OR only. This is a list of some of the procedures that we are doing, that we do them down in the emergency department. There's definitely opportunities for procedures. And if you want flexibility, right? So in schedule, your practice setting, you want to pursue other things in your life, EM is going to be a good place for you. We have a lot of say in our schedule, so I don't exactly pick out my schedule, but I put in requests, and I think I've gotten every single request that I have put in. So if you wanted, you could work all your shifts in the first 2 weeks of the month and do whatever the heck it is that you want to do for the next 2 weeks, the second half of the month. And I know people that will, you know, front load all of their shifts into the first 2 weeks of the month, take off the last 2 weeks of the month and the first 2 weeks of the next month, and then backload the second month's shifts into the last 2 weeks. Now you have 4 weeks to do, you know, like I said, pursue other ventures, travel, do family stuff, whatever you want to do. So we can jump into cases, and I'm going to have you guys, I would need you guys to speak out if there's any answers or questions at this point because I can't see the chat. So the first case here is a 70-year-old. He's coming with some sharp intermittent right flank pain. He's never had anything like this before. There's nothing that seems to make it better or worse, and he hasn't taken any medications for this. And this is acute pain. Sounds like it just started. So his review of systems, this just to keep it simple, it is truncated. He has no chest pain, shortness of breath, nausea, vomiting, no urinary symptoms, and no fevers or chills. He has a history, past medical history of hypertension, hyperlipidemia, CAD, and some diabetes. And he's not had any surgeries in the past. His social history, he does smoke tobacco, no alcohol or illicit drugs. He is married, and he is a retired teacher. His medications are aspirin, lisinopril, metformin, and NKDA is no drug allergies, no known drug allergies. So it's going to be a little different than how you learn in medical school. You will get the history, you will do your exam, and then come up with your differential. Personally, and in the emergency department, I find it more helpful to kind of get the history and then have my differential in my head, because I'm there with a very specific purpose. My purpose is not to identify the exact diagnosis. My purpose is to make sure it's not an emergent, life-threatening diagnosis that needs to be intervened upon or treated right now. And if it's not one of those diagnoses, I will do my best to find out what it is, but it will likely need outpatient or further follow-up that I'm not going to be doing, right? So if anybody can share or tell me some of these diagnoses. So this is how I break it up. Give me 3 that are going to kill you right now that I need at the top of my list to make sure you're not having, and then some 3 other, important but less lethal diagnoses. Trying to get to the chat. Oh my gosh, so many things in the chat.
Yeah, those are just questions that people have been asking overall.
Oh, got it. Okay.
Yeah, those are questions.
Maybe I will go for, I'll just keep moving then.
Yeah, okay, so someone in the chat said appendicitis.
Yes, agreed. Right upper quadrant, it's usually right lower quadrant we're thinking about, but you can have a retrocecal appendicitis. Lots of non-textbook things that you will find. So yes.
Yeah, someone also said IBD.
Yes.
Peritonitis. Yeah, peritonitis. Yep. Yeah, appendicitis again. Good.
These are good. I'm going to get into the list that I had made for us. So, in this guy, a 70-year-old with a history of heart disease who smokes, my top list, atypical MI. Okay, so that means a STEMI, a heart attack, myocardial infarction that is not presenting with chest pain. Older patients, those with diabetes, they tend to have atypical symptoms. So they may come with abdominal pain, but it's actually a heart attack. AAA, that's a ruptured or leaking abdominal aortic aneurysm. That's really high on my list because of his age, his gender, his smoking history, and known cardiac history. Mesenteric ischemia, so like an embolus or something that's blocking blood flow to the abdomen, can also cause a lot of abdominal pain and is a high risk diagnosis that you need to identify quickly and address. 3 other less lethal diagnoses, so you'll see appendicitis on there, pyelonephritis, so infection of the kidney in the right flank, cholelithiasis, cholecystitis, so gallstones or gallbladder with stones and infection. Those things are important. Number 1, cholecystitis and appendicitis typically need surgery, they need antibiotics. Cholelithiasis just needs some symptomatic management. Pyelo needs some antibiotics. So they are important. I need to find those, but they are less likely to kill you as quickly as the list on the left. So these are his vital signs. He has a temp of 97.6, a heart rate of 101, blood pressure 78/44, respirations of 24, and he's satting pretty well, 98% on room air. In the ER, we do just the appropriate focused exam, right? I'm not going to be looking at this guy's ears and throat or, doing things like that, or because it's just not relevant to his case. So he in general is uncomfortable, he's pale, he's sweaty, that's diaphoretic. His cardiac exam, there's regular tachycardia. So you see his heart rate is above 100. He does have some tachycardia, no murmurs, gallops, or rubs. His cap refill is less than 2 in all 4 extremities. His pulses, he's got 2+ radial pulses. His femoral and DP pulses, though, are a little bit lower. They're not as robust. Is that because he has, heart disease and vascular disease, or is that because there's something going on right now? Not entirely clear, but we noticed it. Respirations, his lungs are clear to auscultation bilaterally. He has no wheezing, bronchi, or rales. His GI exam, the most important part here, he's obese, he's non-distended, but he's tender, diffusely tender to palpation. He has some rebound, no guarding. GU exam, extremely important to do in everybody that's coming with abdominal pain, because you can have issues in the genitals that are actually referring pain to the abdomen that you don't want to miss. He luckily has normal external genitalia. There's no rash, there's no tenderness. His neuro exam, once again, a focused neuro exam. He's awake, alert, oriented ×3 and has no focal deficits. So I want to know, what do we want to do? What do you guys want to do for this gentleman? Anybody want to get an IV? Should we do fluids? Should we give him any medications? So for this guy, you know, based on our differential and the exam that we have, AAA is at the top of my list.
Yeah, so someone said imaging, someone said CT.
Yep. Is he okay to go to CT right now? Like, what's the next step, right? So any of the exams you're taking, they're going to say, what's the next best step?
Mm-hmm.
Can this guy go to CT? So I will say these are the things that I'm going to do for him. I put them, it's really hard in EM and even on your exams to say what's the next best step, because in actuality, I'm doing all of these things at the exact same time. Nurse, get a line, get him on the monitor. Tech, get the EKG leads on right now. IV O2 monitor is something you're going to hear a lot, especially for exams. Your patients are sick, they need an IV O2 monitor. That's the first step, IV O2 monitor. I put O2 in parentheses here because he's not hypoxic, he doesn't actually need the oxygen. But the nurse is going to work on that, work on getting him on the monitor. I have a tech that's going to get me EKG leads on the patient. Another nurse is going to draw off some labs, right? CBC, CMP, lipase coags, type and cross, possibly a troponin. We're going to get some fluids running. I'm going to make sure I'm ready to give him blood products if he needs it. And we'll get to imaging in a second, but I'm also going to talk to him about his code status. That's something I don't usually have on file, but a ruptured or leaking AAA is like universally lethal without aggressive interventions. So if possible, I want to have a brief but quick conversation with him, like, hey, I think this is going on. I need to discuss some wishes. Because if this patient codes in front of me, I'm going to code him. I'm going to try to resuscitate him. But what if those aren't his wishes, right? So I just want to make sure we're on the same page. Imaging, you have two options. You have CT and you have POCUS. I don't know if any of you guys know what POCUS is, but that's point of care ultrasound. We do a lot of ultrasound in the emergency department. I use it almost every day, and that's something that's been emerging in the last decade or two. So CT versus point of care ultrasound. Which one and why? Let's see. So we're going to go ahead with an ultrasound, right? And I'll tell you why. So if this person was stable, so good heart rate, good blood pressure, physically looks stable, he can go to the CT scanner, right? But this guy's not stable. He's tachycardic, he's hypotensive, he's pale, he's diaphoretic. I'm really worried about this person. So I'm absolutely not sending him to the CT scanner. I'm going to have someone grab me the ultrasound, or I'm going to run and grab the ultrasound, throw the probe onto his abdomen, and try to look at his aorta. So let's see. Oh no. Can't get this to play. Ooh. Let me see. Let me stop my screen share for 1 second because I do really want to show you this video. Sorry, guys. I tested that like so many times. But does that make sense?
AAA has been an advocate for travelers for more than a century.
Not AAA.
This video.
Oh yeah, so like when you ask the questions, just like a heads up, it's a little delayed. There's a little lag on YouTube Live. So like
okay.
get the question like a little bit after you ask it.
Sure. Yeah, no problem. I just don't want to like sit and wait in case no one
Right, yeah.
saying anything. But so let me see if I can get this video to go. Can you guys see this on your screen, the video?
Mm-hmm.
Okay. So I'm just going to do a short clip. You know, ultrasound, even just the AAA ultrasound is like a whole lecture in itself. So
Criteria of a AAA greater than 3 centimeters. This video clip is another short axis orientation of a very large AAA in a patient presented to the ED with abdominal pain. We mark the spine as our landmark, and anterior to the spine, we see a very large AAA. Notice the true lumen and the accumulation of thrombus that's seen substantially anterior to the true lumen. Next, we'll measure this AAA, and here we've placed our calipers from outer wall to outer wall in a short axis configuration, and we come up with an aneurysm of 6.3 by 5.8 centimeters, again, making the criteria of a very large AAA greater than 3 centimeters.
So that is something that I would, you know, kind of like what I would see on my ultrasound. And like I said, this guy is not stable. I am not comfortable with him going to the CT scan. So the next thing I'm going to do is call the vascular surgeon, and he's going to go to the operating room and hopefully live. So AAA itself, the definition is a abdominal aorta, transverse diameter from the outer wall to the outer wall of greater than 3 centimeters. If you go down to the internal iliacs, when the aorta splits, it's a diameter greater than 1.5 centimeters. So it's just half of the 3, which is good to know. Now, outpatient, they perform elective surgery for aortas that are greater than 5.5 centimeters in males and 5 centimeters in females. So it's about 4.5 per every 1,000 patients will have this, and the majority are infrarenal. Risk factors, our patient had many of these, so atherosclerosis, smoking, hypertension, hyperlipidemia, male gender, higher age, Marfan syndrome, and Ehlers-Danlos. Per the USPSTF, men age 65 to 75 who have ever smoked in their lifetime should get a one-type ultrasound to screen the size of their aorta. Classically, which you may read in your textbooks and definitely remember for your exams, you got a 75-year-old smoker coming in with back pain, hypotension, and a pulsatile abdominal mass, it's a AAA. So only 50% of patients in real life actually present with this. Many of them have like syncope or chest pain, or just back pain. And so almost a third are initially misdiagnosed because you need a high index of suspicion about this diagnosis and to find it. And it's not always obvious until the patient is like severely affected or it's fully ruptured. And at that point, you might be too late. So this person, imaging, we had talked about the CT angiography abdomen pelvis. That is the gold standard to diagnose a AAA. And I wrote stable because that is for your stable patient. Anybody that's unstable should not go to the CT scanner. Unstable, you're going to use point of care ultrasound. Oh, let me try to move this out of here. I did want to give you guys some pearls. So rectal bleeding in a patient with a history of AAA repair, that's an aortoduodenal fistula that, you know, needs vascular surgeon. It needs like OR ASAP. usually have what we call like a harrow bleed. So someone might come in, they say, oh, you know, I had a little bit of rectal bleeding. It's fine now. They look good. You can't let that person go. You know, you're probably think, you know, this could be an aortoduodenal fistula. I just want to go back for 1 second. That reminds me, my first pearl here. So a fast exam, I don't know if you guys are familiar with, but that's an abdominal ultrasound that we do to look for free fluid in the abdomen. So you would think that, you know, if someone's aorta had ruptured, they may have free fluid in the abdomen, and they might, but remember the aorta is retroperitoneal. The fast is looking at intra-abdominal bleeding and free fluid. So a AAA can be ruptured and your fast can be negative at the same time. So the workup, I kind of broke it down into symptomatic versus asymptomatic and stable versus unstable. So someone who's having symptoms like this gentleman, having abdominal pain or hypotension, and they are unstable, that's a hypotension, it's a stat vascular surgery consult, right? I'm getting my ultrasound probe, and like in the other hand, I have the phone to vascular surgery. They need to go straight to the OR for definitive management. In the meantime, in the ER, you're going to get 2 large bore IVs, give them oxygen if they need, support them hemodynamically with fluids and blood transfusion. And you're actually allowed to have them be what we call a permissive hypotension, like a systolic of 80 to 100 is okay. You don't need them all the way up to 120. So don't start pressors and stuff like that to get them really high, because you could actually worsen their bleed by increasing their blood pressure. And pain control, something as doctors, and I feel like especially in emergency medicine, or maybe it's just all doctors, we are not great at pain control, right? We're really good at all of these other things, bang, 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 get you stabilized, but we're not always good at controlling pain. And that's actually the #1 thing that brought him in, so we need to control that. And as mentioned before, expected management, you know, if you don't do any of these things, these people will die. If they're having symptoms like abdominal pain, but they're stable, so they got good vital signs, they're looking okay, call vascular, you'll get a consult. They may, they'll probably admit and plan for surgical OR or surgical repair like the next day or later in the day. And then if it's something that you just found, like you're doing a CAT scan for appendicitis and you see that, oh, hey, their aorta's kind of big, but they don't have any symptoms, they're, you know, looking okay, doing okay, they can see vascular surgery as an outpatient. So the second case is a 4-year-old who is brought in by EMS and mom for shortness of breath for the last 3 days. He's had a progressively worsening symptoms that are associated with some runny nose, sneezing, throat pain, and a non-productive cough. There's no fevers or chills. There's no sick contacts. Mom tells you he did run out of his asthma meds and inhaler last month, and they're not able to get in with the pediatrician. His vaccines, so in children, this is always an important question. His vaccines are up to date, including his influenza. And also in all asthmatics, you want to know if they've ever been intubated and when their last exacerbation was. So he's never been intubated, and his last exacerbation was about a month ago. So he has a history of asthma, eczema, and a peanut allergy, no surgeries. Social history, he's in preschool, lives with his mom who uses tobacco, so he has tobacco exposure. He lives with dad and an older brother. His meds, he takes Zyrtec, Flovent, and albuterol, PRN, and he has no known drug allergies. So same thing like we did last time, like, you know, this one might seem obvious, but that doesn't mean you don't make your differential, because that is when you will be fooled, is when you think that you can just, you know, take the first thing that comes to mind. So I'll give a second to see what you guys put on this differential. So I hope somebody says asthma.
Someone asked, has he had strep in the last 3 months?
I don't know. And it's not a question I would have asked. No, I'm not saying you're not wrong. In the ER, it's not a question I would have asked.
Someone said allergy.
Absolutely. Anaphylaxis.
Yeah, asthma.
All right, I'm gonna show you what I have. So for him, I said asthma exacerbation. It's not only the most likely, but in an asthmatic, that is a potentially lethal situation, given his age and some of the throat pain, less likely, but epiglottitis is also possible. Also, given his age and shortness of breath, foreign body is possible. Anaphylaxis, absolutely. And that would maybe compete for the third point here, foreign body. But I absolutely agree with that. Other things, URI, pneumonia, always on your differential or something you have to think about as child abuse or neglect. Many times the way these kids come in is not with the injury or with the problem itself. It's something that we pick up on exam or something that you just feel in the interaction that you have with the family that something's not right. So that's always, always, always something on your mind. Arguably, this very short differential here, diagnoses from both sides can kind of be on both lists. So if you notice, his vital signs are actually the exact same as our 70-year-old patient for the other case. However, in his age group, he's 3, these vital signs are normal, right? So that heart rate is good, that blood pressure is good, the respirations are good. He's satting well, he's not febrile. Generally, he looks good. He's not in any acute distress. Now, he needs an HENT exam, given that that's, connected to his respiratory system where his primary complaint is. So his pupils are equally round, reactive to light and accommodation. He does have some clear secretions in his nose, moist mucous membranes, little erythema of the pharynx without any exudates, and his uvula is midline. His neck is non-tender with full range of motion, and he does have a little cervical lymphadenopathy. So point about documentation, it's just as important to note what you don't see, like if you don't find any abnormalities, it's just important to say that as it is the normal things or the abnormalities that you do find, right? So if you didn't document it, it didn't happen, right? So what I'm actually conveying through this HENT exam with this mild pharyngeal erythema, but no exudates and the uvula is midline, is that I don't think he has a peritonsillar abscess. I don't think he has strep throat. I don't think he has any sort of pharyngeal primary problem. His neck is non-tender with full range of motion. I'm alluding to meningitis there, right? Although that's not his primary complaint, if you're thinking infection and stuff like that, that exam tells you that, even better, you could say no meningismus. But so his cardiac exam, regular rate rhythm, no murmurs, gallops, and rubs on respirations. He's having symmetric expansion, mild expiratory wheezes bilaterally. GI is normal, soft, non-distended, non-tender, no rebound or guarding. And on neuro exam, he's awake, alert, playful, follows directions, no focal deficits. No 3-year-old's exam should say ANO times 3 because they're not ANO times 3. That's not appropriate for them. In a skin exam, no rashes. So what do we want to do? Ooh, this should be case 2, shortness of breath, not abdominal pain. But what are some things you want to do for this person? Child who's having an asthma exacerbation.
Yeah, just give it 1 second.
Sure.
respiratory steroids.
Mm-hmm.
Probably O2, a new inhaler.
Okay.
Yeah.
All right, so let me go ahead. So this case is a little easier than the last one. So this kid, I would give him some duo-neb, standard like 3 treatments. So a duo-neb is albuterol and another like oh my goodness, why am I totally blanking on the other medication, duo-nebs? I use this every day, but he's gonna get a duo-neb. And some PO steroids. I don't think he needs, we don't really do inhaled steroids. I don't think he needs IV steroids. He looks good. He looks nice and stable. I'm going to reassess, make sure that the nebs that he is getting better, and he's going to get discharged with a PO steroid burst, an albuterol inhaler, an EpiPen. I'm going to do a little bit more than what he came in for, given his situation and difficulty getting into the pediatrician. I want to make sure he has all of the medications that he needs until he can get in to see his peds. Anticipatory guidance, which just means kind of tell mom and dad what to expect over the next few days. If he wheezes again, that's okay. Give him a treatment. If they don't know that and they're not familiar with that, because we don't educate our patients, if he's wheezing, he might come right back to the emergency department unnecessarily. Strict return precautions also goes hand in hand with this to explain exactly why they do need to come back, right? And then some close peds follow-up. And I'd probably give a social work referral as well, just to help parents with their appointments and getting their kids in and getting the medications that he needs when he needs them. So I didn't say x-ray for him. These are reasons this pearl is on when to obtain x-rays in pediatric asthma exacerbation. So first of all, not every asthmatic needs an x-ray. If you imagine people that are coming in at least a couple times a year throughout childhood and even adulthood, that's, they're racking up radiation to the chest pretty quickly. And especially in pediatrics, we like to make sure we're getting x-rays for very good reasons and not reflexively. So this is like the rule of F's, right? So if I'm thinking like foreign body, like, he was playing by himself or he was playing with his little brother, I didn't see what was going on, and I don't hear great lung sounds on one side of the lung, that makes me think more about foreign body. If he has a fever or any findings concerning for pneumonia, I'd want an x-ray. If you give him the nebs and you come back and he's not any better or he's worse, I would want an x-ray because I feel like I'm missing something, or there may be an alternative diagnosis other than asthma. And then fracture, if you're suspecting trauma or abuse for any reason. So your charge nurse, you come out of the room, charge nurse says, great job, doctor. We have a code rolling in about 4 minutes, cards waiting on the phone to talk to you about a patient that they're sending in, and 22 patients in the waiting room. So that is a little flavor of what a part of my shift looks like day to day. Just general advice, no matter where you are in your medical training, learn a proper exam. That is the basis of everything you do. As you shadow, you may feel like we do a lot of imaging, and we do a lot of imaging. CT is taking over in some areas, but CT is not everywhere. Ultrasound machines break, these things happen. So you need to learn a proper exam. You will catch things that, you don't realize. Undress the patient. This is my biggest pet peeve in the emergency department. Someone's here for leg pain. The student or the resident goes to see them. They say, great, everything's fine. I go in the room and his pants are on. How do you know if they have a DVT or not, right? How do you know if they have a skin rash under there that's hiding? How can you take their femoral pulses with their pants on? How can you take their pedal pulses with their shoes on? Those are things that you are responsible for when you're evaluating the patient. So patients don't like to get undressed. They don't understand it. They'll come in with toe pain and say, why are you doing a cardiac exam? It's because you are responsible for everything. Even if they come in for toe pain in the emergency department, I am responsible for head to toe. And if I miss something, that's on me, even if it's not something that the patient brought up, right? So do not miss that opportunity. I've seen chest pains, right? And they're getting their EKG and the tech goes, hey, what's that rash on their chest? Oh, it's shingles. They don't even need an EKG, right? If you did the proper exam and you saw they had shingles on their chest, you could just write in their acyclovir and they're done. It's probably not a cardiac thing and you may not need that EKG. The next point takes some time, but find and stick with some good study habits. Like, they were definitely not kidding when they said lifelong learning. Like, I am still doing lectures, I am still studying, because there is so much to learn, even after residency, you know, not just keeping up with what the most up-to-date recommendations and studies are, but there's a lot to learn. So finding these habits are going to help you through undergrad. They will help you through your medical school and through residency, and hopefully keep you efficient, right? Don't be wasting time. You got to figure out what works for you. What works for you may not be what works for, you know, your friends. Be honest with yourself about what you do and do not like, right? I found this myself falling into this trap a little bit about, oh, this specialty sounds so cool, you know, like, oh, and they make a lot of money and that's great. But like, glamour and money does not equal happiness. And you're going to study hard. Medical school and residency is not easy. And if you don't like what you're you know, investing all your time and energy into, you're not going to make it. You know, it's going to be like hell. It's going to be really hard to get through, and you may not be a very good physician afterwards as well. Fit medicine life into your real life. So as I was writing this out, I wrote fit real life into your medicine life, because I feel like that's how we're thinking while we're training for medicine and to be a doctor. Your life is medicine, and you forget that you have a real life or life outside of medicine, right? Like family, friends, kids, travel, reading, exercise, whatever it is you like to do. Remember that medicine is a part of your life. It is not your whole life. So you need to, you know, make the other parts of your life a priority as well. The White Coat Investor is a book that I recommend everybody reads. Medical school is a good time to read it. You could read it before. If you're beyond medical school, you can read it at any time. Really, it helps people with our unique financial situations, which is usually carrying a lot of debt throughout medical school and residency, and then coming into a sizable salary, on how to manage your money, because that's something they will not teach you in medical school. How to manage your loans, what strategies should you have with your finances, how should you set up your 401k, stuff that is extremely important for people like us, but we don't learn in medical school. The last point is to hold your head up high, but not too high, okay? Be humble, be kind, and be a good listener. So hold your head up high. Do not let anybody in medicine demean you or undermine you or discourage you in any way. Stand up for yourself. But do not be cocky, do not be a know-it-all. Nobody likes that person, right? When you first get to a hospital and you're the brand new person, you're gonna walk in like, you know, I'm Dr. So-and-so, but you're still there to learn. You don't know everything. Introduce yourself to the nurses. One strategy I had, I just would play really stupid, right? I'd be like, oh, how do you do this thing? Or where is this thing? Just to convey that hey, I don't know everything. I know I don't know everything. We're going to work together as a team. I'm here to learn from you. You're not learning from just your attendings or other physicians. You are learning from everybody on the team. You're learning from the nurses. You're learning from the techs. You're learning from other specialties. There is a lot to learn. And I found I actually built better relationships this way, and learned a lot more from my colleagues by interacting with them like this. Here are just a couple resources if you are interested in emergency medicine. EMRA is a great organization, the Emergency Medicine Residency Association. They have made these apps, actually 2 of them that are up at the top, or actually one of them, EMRA Antibiotic Guide, as well as some other guides that are really helpful for on shift or just for learning and studying, and then the American College of Emergency Physicians as well. You can reach me at my email or follow me on Instagram there, and note down these apps up at the top. Some of them are free, I believe. Some of them cost money, but they are really helpful. PDStat is really good for pediatric emergencies. You just pull it up. You can put in the date of birth or the weight or the age, and it'll pull up all of your medications in the doses that you need for different emergencies. Okay. And I guess let me get out of this and I can kind of go through the chat and try to get through some of those questions. Oh gosh, where to begin? I'm just going to go through start at the top, and then we'll move on to a little bit about breast cancer. So I'll read the question out. Was I able to practice while I was in treatment? We will get to that, but no, I had to stop working because of chemotherapy. My initial reaction to finding out I was diagnosed with breast cancer, we will also get to that. What is the most challenging part of your job? I think there's a lot of challenging things, but I think, for example, swinging from one end to another. Like, so for example, you see somebody that came in, they had something really bad going on with them, let's say a AAA, you pulled out all the stops, they coded, and they died, right? You've spent like 2 hours with them. You come out of that room, you are just trying to emotionally process and reset because you have all of your other patients waiting for you. Doctor, where are you? Oh, Dr. Jack, oh, she's not doing anything. I don't know what she's on the phone. Oh, she's on the computer. She's not taking care of me, but they have no idea what I was just dealing with and what I'm processing myself, nor do they care, nor should they. They're not there for that, right? They're there to be cared for. And you need to kind of switch, get back on your feet and go take care of your other patients. So kind of switching between those situations, I still find that challenging. And due to HIPAA, yeah, you can't tell them, you can't even simply explain to them what happened. So I do find that to be challenging. Having breast cancer and physician alter your perspective in regards to patient care, mortality, and health. Yes, and we'll probably touch on that a little in a second. Thank you for talking to us. What would I consider the essential skills that every emergency medicine physician or someone in this field needs to have? So aside from some of those skills I mentioned in the PowerPoint, like, you want to know a little bit about everything, you can be calm under pressure, you need to be organized. You need to be organized not only at work to keep track of all of your different patients and complaints and their different levels of workup, and to make sure that you can move through that quickly, but you need to be organized in your personal life. Like, we have a Google Calendar I have with my husband, my family members, my brother. We all have different portions on the calendar to help us. We have a nanny that's involved in our lives. And as you can imagine, my schedule with my husband's schedule, it's just a lot to organize. So who's going to pick up the kids? Who's taking care of the kids? So you need to have some good organization skills and good communication skills. We make a lot of phone calls. Once you get to medical school, you should have be taught about how to call a consult, right? That sounds so stupid. Like, you just pick up the phone and say something, but it's actually really complicated to make an efficient and effective consult call. So you need to be able to communicate and advocate for your patients. How do you remain calm and collected during serious and extremely time-sensitive cases arriving to the ED? And how are you able to compartmentalize your emotions after cases with bad outcomes? So I remember learning in medical school, you're learning your ACLS algorithm, which tells you if you think that somebody is coding, you check their pulse first, right? What I learned was, no, it's the first pulse to check is actually your own, okay? Take 1 second, take your pulse. You need to get your mind ready for the situation that you're walking into. Because if your heart rate's running 200 beats a minute and all these thoughts are racing in your head, you're not in a good place to actually go care for that patient that needs you. You need to be in the best place. You need to be optimized so you can go provide that care. So when I know a code's coming in, or I see the code running in, or shoot, my patient, they just flatlined, I'm running over there. It takes literally like 2 to 3 seconds to take a nice deep breath, whisper something to yourself, gives yourself a little boost. I just tell myself, you got this. It sets my head right. I walk in, ready to go. How do I deal with my emotions afterwards? I am still finding ways to do this. It's really hard to not be able to process them in real time sometimes. So if possible, no matter what the situation, I like to take a couple minutes, just either I'm by myself or speaking with family members of the patient that may be effective. I find that that's very comforting to just have an understanding. And I think mutually it's comforting for them to have that relationship with the doctor as well. I talk to my colleagues, my medical colleagues, where you can kind of explain a little bit, some of the medical intricacies that are contributing to your emotions. Just debrief with my team. That's really important for your team members. And those are kind of ways to process. What are the most common, I got lost. I think it said, what are the most common cases that I see in the emergency department? Are they cardiac related or mental health? I see a lot of cardiac, I see a lot of respiratory, I see a lot of neuro, a lot of GI, and a lot of mental health. So I really see a lot of everything. Mental health is an increasing thing that we see in the emergency department with its own challenges of addressing mental health and patients, especially mental health emergencies. And every place it has different processes to handle that. Ooh, sorry. Where do I see my discipline going in the next decade? How will EMS change or adapt? That's a really good question. I think emergency medicine is actually expanding out, not only of the emergency department, but out of some of the things that we're doing. We're having some advancements in procedures and different things that we can do to help with our patients. So I'm not going to touch too much on that, but I think we are advancing in our reach. And that's not to be threatening to other specialties. It's just to be able to provide better care to our patients. So I think we're learning some new procedures, some new techniques, a lot of ultrasound, things like that. We may be doing esophageal, like transesophageal ultrasounds actually during cardiac arrest to help us out. That's a procedure we don't really do right now, or doing more ECMO and things like that. There's pushes for that. How will EMS change or adapt? That's a really good question. So like every state has their own EMS system, so it's kind of hard to address that. But I actually, interestingly, a family member of mine is working locally in DC, where they have this model that EMS will basically come out, it's through a private company. EMS will come out and kind of assess the patient and help to mitigate people going to the emergency department that maybe not needing to go there, right? To kind of reduce our burden and doing some of our work out in real life, like face-to-face with patients. So I think we work together pretty well, generally well. I have a good relationship with the EMS people that come to my hospital, and we rely on them heavily, right? Like they have all of any available information of what happened before the patient gets to the emergency department, especially when the patient can't tell us. They are really useful. How has COVID changed my schedule? So I am actually I did see some COVID patients, but I stopped working because of chemotherapy. I will be back next month. So I can tell you there have been some schedule changes with hours and the level of coverage and stuff like that. But next month I can tell you better. What is one thing you wish you knew as a pre-med that you knew now? So I would say, I don't know why I had this false belief that like I would reach this point where I felt like I knew everything I needed to know. Like, yes, I feel like I know the majority of things that I need to know, but I never reached this level where I think I could stop studying. And I just wanted to know, when can I stop studying? When do I have to stop doing all of this? And let me break it to you, it doesn't stop, right? So that's why you want to get those study habits down. You want to get a schedule down, because this is lifelong. You're going to be studying for CME. You're going to be studying for your board exams. You're going to be studying for your own knowledge. Like when you're an attending and everything is on you, you better believe you want to know exactly what you're doing and stay up to date on all the literature. I might actually, because of time, do you want me to skip ahead to the next one?
Yeah, I'd say go ahead and get started on the next one. And then, yeah.
Awesome. Let me just pull that up. These are great questions though, you guys. I'm happy to try to send some answers via email. So I'll try to go through this quickly so I can get to more of the personal information, but So this is just a brief talk, hopefully, on breast cancer. I am a breast cancer survivor as of July of this year. So this is near and dear to my heart. Just very, very basics. This is the most common cancer diagnosed in women worldwide. I think recently skin cancer may have jumped to the #1, and now this is #2. But for a very long time, this was #1. It kills like 500,000 women worldwide every year. And with the exception of stage 4 or metastatic disease, breast cancer is curable. Risk factors include if anybody in your family has had breast cancer. Don't forget this includes men. 1% of breast cancer is in men. Family history, genetics like the BRCA1 or BRCA2. Prolonged exposure to estrogen, whether that is endogenous or endogenous or exogenous, either way. Alcohol use, smoking, obesity, physical inactivity, those are your modifiable risk factors. And the majority of women, such as myself, have no identifiable risk factors. Breastfeeding is actually found to be protective and reduce risk of breast cancer. The survival rates vary worldwide, but here in the US, we're towards the top when we have about 80% survival rates. But in some less developed countries like India, I was talking to medical students there this morning, and we were talking about this why. The survival rates are like less than half what they are here, which is just so ridiculous and frustrating, but it has to do a lot with lack of programs of early detection and places to go for diagnosis and treatment. So early detection is the cornerstone of improving breast cancer outcomes and survival. Early detection means earlier diagnosis, which means earlier treatment. And those that are diagnosed in earlier stages have like a 93% 5-year survival rate, which is, pretty decent. So awareness of early signs and symptoms and the breast exam can pick up cancer possibly in patients that are having symptoms, and then screening can help pick up cancer in patients that are, or people that are not having active symptoms, of which mammogram is the only screening method that has proven to be effective, okay? It can be complex to interpret, costly, and requires a lot of coordination. So there are some challenges with that, more in the less developed countries than in the US. Per the American College of OBGYN, and an average risk individual, you use shared decision-making to select your screening choices. So CBE, which is a clinical breast exam, can be offered every 1 to 3 years for women aged 29 to 39, and annually for women greater than age 40. And then a biannual or annual mammography starts at age 50 and is up to 75. It can be offered at age 40 if a patient desires. Increased risk individuals, so if you have that family history or you have BRCA, mammograms start at age 40 or 10 years prior to the earliest age that it was diagnosed in a family member. So breast exams, there's the self breast exam, which you do at home, and then the clinical, which is performed by a physician. So this is really important to know that the self breast exam, there is no evidence that on the effectiveness that it has in diagnosing breast cancer. Okay, it has been found to empower women to take responsibility for their own health, and it is recommended by the WHO to raise awareness of breast cancer in women at risk. So you know that it has no evidence, but 40% of breast cancers are detected by women on a self-breast exam. Clinical breast exam research is ongoing. It might be useful, and preliminary research shows that less advanced staged breast cancers are actually being diagnosed with the clinical breast exam. So it may be useful, more to come. So I'm not even going to read through this, but I think there is some controversy between the guidelines and what's being practiced with the self-breast exams. And this is just to show you through all of these different places, colleges, and people that make guidelines, there is no consensus or clear recommendation to do the clinical or self-breast exam. Many places are doing or promoting what they're calling like breast awareness, just that women should be aware of their breasts and what they look like, and be monitoring themselves for any changes from their normal. So this, just so you can understand abnormal, it's important to know what the normal is. There's a lot of variability in normal, but breasts can normally be slightly different sizes. They can be asymmetric. They can be slightly different shapes. Nipples can point slightly in different directions. The last image here, image 6, you see an inverted nipple. Some people can have this as a normal variant, which is why it's really important for women to understand what do they normally look like, right? Because if we see this 6, we might say, oh my goodness, it's an inverted nipple, we need to get her worked up for breast cancer. But if she says, oh, it's always been like that and it doesn't look any different, we might be a little less concerned. This is the breast exam. I teach it in 2 different steps just for simplification for physicians and then also for you to be able to teach to your patients. So the first step is just to look, stand in front of a mirror, put your hands above your head. You're looking at the color, the size, the shape, the movement. Put your hands on your hips, look for the exact same things, and then you can put your hands down. So check in those different positions. The second step is to feel. You're going to use about the pads of your 2 fingers, make just gentle circular motions of pressure with pressure onto the breast. And you can use one of these 3 patterns down here. So radial, like kind of going like the spokes of a wheel. You start at the nipple and go out, move over. Start at the nipple, go out. Spiral is starting closer to the nipple and areola and going outwards in a circular motion. And then vertical is just going up and down. Whatever you do, just pick one and stick with that method, and make sure to also examine the nipples and then all the way into your armpits, okay? So this is not just the breast. You are going from collarbone down to the upper abdomen and from the side of your chest all the way to the other side to make sure you don't miss any abnormalities. As I said, it's important to do it consistently. So pick one method and stick with it. And regularly pick one time of the month and stick to that. There's in the media, at least there's a hashtags for feel it on the 1st because that's a really easy way to remember when to do it. Some people recommend actually mid-cycle, mid of your menstrual cycle, which would actually be a few days after your menses. Once again, just pick one and stick with it. And the most important thing, you don't have to remember the whole list of all these abnormalities that we're going to look at, but any change from your normal or from your last exam is a red flag, so get to a doctor. And if you're a doctor and someone brings this to you, work it up. Here are some abnormalities. So the top, starting from the left, you see some skin discoloration. You can appreciate a small mass here. There's some skin discoloration and tugging, tugging of the nipple and areola to the outer side. In these middles, you can appreciate that both of these breasts look drastically different, and it's actually the left breast here. You can appreciate a fullness and what looks to be a mass. There's also a mass, and here's a mass. So these are some more obvious ones that you can see just from looking. The second row of images shows some nipple abnormalities. So you can see like this half of the areola and nipple, it's all crusted and the skin looks different. You have some puckering and pulling of the areola here. This image is a little hard to appreciate, but this left nipple is inverted and pointing in quite a different direction than the other one. And you get the idea. 24 is just, there's a problem that just does not look right. Here are some more skin changes, rashes. This is something you might see with inflammatory breast cancer, which often presents similar to mastitis and gets misdiagnosed as mastitis. It's rare, but it's in a difficult to diagnose form of breast cancer. And then this last image is the peau d'orange, where you see this skin texture looks kind of like an orange peel, and obviously an inverted nipple. So I can get out of this and then just tell you if there are any questions, or if you want me to do questions, or I can just kind of jump into what it was like when I had breast cancer.
Yeah, I think you can just like jump into how your experience with breast
cancer.
Yeah,
Yeah, absolutely. And thank you guys for sticking with me. I know we're covering a lot of information here. So last December, so December 2019, I just had a pain literally, it was like Christmas week, and I just instinctively grabbed, and I felt a mass, and that's how everything started. I did not do self-breast exams because of the recommendations from all of the guidelines that I just kind of showed you, that we learned in medical school. And as a good med student, I know the guidelines and I followed them, and I understood the research behind them. I still do today, but now I do my self-breast exams because I wonder if I would have caught this a little earlier. And if I hadn't had that pain, how much longer would it have gone on before I realized what was going on? So I had just moved from Philadelphia to DC. Got my daughter's doctors, my husband got a doctor. I had just started my job as an attending, and I was just settling down. So now I got a doctor. And she said, oh, well, you need a mammo and an ultrasound. And I was like, really? Like, don't you think I just need an ultrasound, right? Because I thought it's a fibroadenoma, it's a cyst. Those are the most common benign tumors, especially in women of my age. But I said, you're the doctor and I'm the patient now, so I'm going to go with whatever you recommend. The next week I had the mammo, I had the ultrasound, and the radiologist came in right away and said, we need to take you to do a biopsy. And I was like, show me the ultrasound. I don't know, this seems a little extra. And I couldn't, they wanted to do it same day, but I had to work a shift that night. I had to get the kids from school. I had to sleep. I was like, I will come back. I came back next week. They did the biopsy. The following week, so this is like several weeks, I got the diagnosis. I had the patient portal that I pulled up and I saw invasive ductal carcinoma. And I was like, what? Like, I know what that is, but it's not my results. Clearly they have mixed me up with somebody else. That's what I thought. So I called the next day to tell them. They confirmed that no, they were my results, and we had to start chemotherapy. I had to go through several more tests before starting chemotherapy, and it just kind of took off from there. So when I was diagnosed, it's just hard for me to go back all the way to that point because I'm in such a different place right now. But I think it's important to know, I straight denied it. I did not believe it. I was discouraged, I was depressed, I felt defeated, I was confused, I felt betrayed, by who? I guess my body, right? What the heck did my body do? How did this happen? Why did this happen? I had a million questions. And over time, I realized most of them I'm actually not going to get an answer, right? I can't figure out the how and why. There's no test you can do to say how and why, right? I analyzed every aspect of my life leading up to this. Did I do this thing? Did I do that thing that put me at risk? So it was really confusing. And then chemotherapy started and you start to feel ill, and it kind of came to a point of well, I can just wallow and wither and just go along with it, or I can show up to fight, right? Those are my two options. Even though I'm hating on my body and stuff, it's my body needs me to help it and support it through all of this. And that's what I chose to do. So that's kind of what happened. I went through chemo. I went through 8 cycles of chemo over the course of 4 months. And then I had a partial mastectomy and a lymph node dissection July 22nd, the results of which came back negative for any signs of cancer. So I was staged at a stage 2. That day, I also had from plastic surgery, I had a bilateral breast reduction, which was part of the reconstruction. And I had an ovarian cyst removed and I had my port removed. So it was just a lot going on. But I reached remission, which was really awesome. And then my next concern was, what are the chances this is going to come back? And I was quoted a 1% chance a year of this coming back, and that was cumulative, meaning 5% chance of it recurring in 5 years, 20% chance of it recurring in 20 years. And I didn't feel like that's something that I could go forward with. It didn't feel like, and if it's going to come back, it felt more like, when is it going to come back? So I went forth with the double mastectomy, which I had 1 month and 1 day ago. And I'm just finishing recovering from that, and I'll be headed back to the emergency department. That's really it. I have a lot more to say, but I don't know if you want me to say that or you want me to answer some questions maybe.
Oh yeah, that was really great. Thank you so much for sharing your story with us.
Of course.
Yeah, that was really heartfelt and touching. Yeah, if you want to go through some more questions, that would be great, especially because we're running like a little late on time and stuff.
Sure. Yeah, let me get through some of it. Okay. So this is a question that I get a lot. Let me just start with this, then I'll go backwards. What's the most interesting case that I've had? And I'll be honest, it's not sexy. I don't have one. Or, you know, people will say, what's the craziest thing you've seen in the ER? And let me explain why I don't really answer that question. When you're in the ER, you're going to notice that you are seeing people on their worst days, right? It's a normal day for you, but it is their worst days. I see people in their worst moments. I see some people at the end of their life, right? And I see people in some very embarrassing and compromising situations. Not only is there HIPAA, but for the sake of that person and advocating for them and protecting their situation, I don't share those stories. You would not want to be an ER patient and then find out that all your business was aired publicly to somebody else, almost for like entertainment value, right? So medically relevant, there are some things, but in general, I don't like answering that question for that purpose, right? We are doing a disservice to our patients, I think, if we are using them for those stories. Has COVID changed my schedule? Yes, we did that. What age range are the patients you commonly deal with? So I deal from birth to coffin, anybody, even prior birth. I take care of everybody. Pregnant patients, pediatric, adults, geriatrics, everybody. Do you have specific protocols for different age groups? No, I don't. The protocols we have are usually related to the diagnoses or the complaint that they have, right? So there's protocols, there's a stroke protocol, there's trauma protocols, STEMI protocols, and things like that. Were there any other residencies that you were interested in? Yes, I considered surgery and OBGYN. I liked the procedures and I thought OBGYN had a nice mix of both OR and clinical work. And I went into emergency medicine for the flexibility that it offered me with my schedule in the practice setting. And I do still, as you saw from the list, I don't go in the OR, but I do perform a fair number of procedures. My typical day, we kind of covered that in the lecture. How do I balance life and work? This is an active process, you guys, that I am still figuring out. So if you haven't figured out, please tell me. It's through a lot of support from everybody around me. That is from husband, that's from my mom, my dad, my in-laws, who are basically my family. We have a nanny. Everybody helps to contribute to that. What influenced me to go into emergency medicine? So actually a lot of the pros and cons that I talked about in the talk were things that helped me reach that decision, especially deciding from surgery and OBGYN. Do I know any MD PhDs? Yes, I do. And did I ever do research? So I did a lot of research in undergraduate. I did not consider the dual degree because it was such a daunting amount of time. And after doing a ridiculous amount of research in undergrad to help me get into medical school, it just wasn't something I was interested in doing. I feel like I forced myself to do it because that's what you have to do to get into med school, right? And I realized if I wasn't going to medical school, I may not have done it. So doing a dual degree was not the route for me. I do know some MD PhDs, and that is a very personal decision. You know, like I said, be true to yourself on what you do and do not like, and that will help you make that decision. Wondering how the pandemic affected my everyday work routine. So I did mention I'm out because of the chemotherapy, and as I'm healing up from surgery, I will be back. How is residency for you? How is residency for anybody? Like if someone says easy, also please let me know what field they're in. Maybe I can take some guesses. No, I'm kidding. I'm not hating on any specialties. Residency is challenging for everybody. I really liked my group of residents and my colleagues, and that's what made all the difference through, you know, for getting through residency, kind of like as a family together. Another thing about EM that we touched on, was I always interested in EM? Interestingly, when I was doing my post-bac, I did some research with an EM physician, and that was more out of opportunity, not interest. So I had some exposure, but it wasn't, I didn't go to medical school with the mindset that I was going into emergency medicine. How long is a typical shift? So they can range from 8 hours to 24 hours. The most challenging part of medical school, I can't pick one. The whole thing was challenging. I really struggled with all of the studying. I would say as you go higher up, you know, especially I'm talking to those in undergrad, as you go higher up in your education, it will become more interesting. I think undergrad I struggled because I didn't understand why chemistry and OChem and physics and Calc 2, you're not really going to use that stuff. I think it's really weeder information or weeder classes, right? To just see, can you handle the rigor of medical school? So there's that purpose, but it had a really hard time understanding the connection between the things I was learning and what I thought I was going to be doing eventually. So med school was a little bit more interesting, but still challenging. The studying, you know, there's some competitiveness, all of that was challenging. In what order do you approach patient care in the emergency department that allows you to practice efficiently? Okay, good question. So as you know, we're in triage system. I see the sickest patients first. That's my approach, really. I see the sickest patients first and try to get to some lower acuity patients as I can. You know, you can handle one really sick patient, but multiple less sick people. So it's kind of about divvying up the work, but also doing your fair share. I keep a list, always a running list of all of the tasks that I do. As you're a resident or you rotate through the hospitals in third year of med school, you'll notice most residents too. Everybody has a way or their own way to keep lists of things that are going on because there's just so much to do. How many emergency medicine physicians work at your emergency department at the same time? Okay, good question, because I forgot to touch this in practice settings. Usually at one hospital, we always have two, at the very least 2 physicians on. There's a short period, like 1 or 2 hours overnight where you're by yourself. The affiliate hospital I work at, it's me. That's it. I'm the only ER doctor that is responsible for everybody. How long have I been working in EM? Well, I graduated in 2019. So if you count residency, this is my 5th year. If you don't, this is my 1st year as an attending. Can stress cause an aortic aneurysm? That's a good question. I can't tell you definitively that it's a documented risk factor that I know, but I think it's possible. Oh, how do you personally deal with addressing some of the common practices in EDs that contribute to health disparities? So increased GFR thresholds for African Americans, reduced pain management. So first of all, this is a great question, and I love that you're informed about this. First of all, being informed is the very first thing, right? Like I just learned something recently about actually pain management of African Americans in the emergency department. Just to know that these things are there means that you can counteract them, right? You're aware, so you're thinking about it, and you can counteract with your practices to be on top of these, to reduce these health disparities. You can educate those around you, including your patients, about these disparities, and that's the best way, I think, to handle that. If I didn't choose emergency medicine, what other field? Oh, it kind of touched in surgery, OBGYN. What do you recommend for non-traditional students that are going to medical school? Learn your good study habits. Just because you're non-traditional, as I was talking prior to this talk, like the path is becoming less traditional in that anybody and everybody can go to medical school. You do not have to follow the path that is, you know, the traditional path. The non-traditional students, I think, actually had the most to contribute, and I learned more from them than I did my colleagues that went straight to medical school and, you know, followed this, you know, path, quote unquote. Reach out to others, do not feel inferior, get some good study habits done. Is being a doctor worth many years of study and hard work? I'm still figuring that out. I would like to say yes, and I think I will get to a better place when I can get back to the emergency department and figure out my attending life. What is your favorite part about emergency medicine in regards to other specialties? I don't take call. That's awesome. And I do things where I see immediate results, right? Abscess, I drained it. You're welcome. You're good to go. Pain, here's medicine. You're welcome. You know, it feels better. I do things that make patients feel better immediately. VTAC, boom, no VTAC, you know, things like that. So it's pretty cool. I think that's all of them.
Yep, looks like it. Thank you so much for your time, and thank you so much
Absolutely.
for talking to us.
Yes, I'm sorry I ran over.
No, that's perfectly fine. We got a lot of great information, and you talk about breast cancer was very touching as well. Thank you so much for everything. And then for everyone who's still watching, there is the Google Forms that we posted earlier in the chat, and we can post it one more time. Just make sure to answer all the questions about stuff that Dr. Jackson talked about today, and then also put your research bullet points in there as well, and a summary of what you learned. So that will be, we'll leave it open for about like 5 more minutes so that you can keep submitting your responses in. But yeah, that's about it.
Thank you so much. I'm gonna throw my email into the chat too. If you have any other questions, do not hesitate to reach out to me. I try to respond within 24 hours. I do my best. I can't promise, but I try.
Yep. All right. Thank you so much, Dr. Jackson. We really appreciate it.
No problem. Bye.